What we're going to be talking about is hyponatremia and hypernatremia. And so these are some of the things that I'm going to be covering. One second, let me just move this out of the way so I can see the screen a bit better. So what we're going to be covering is a couple of details on why it's important. And we're going to talk about each hyponatremia and hypernatremia and cover things like how to know when it's severe, how to assess it, and then talk a little bit about diagnostic algorithm that we tend to use and how to go on with management of each of these. So I'm Akash Doshi. I'm an ST3 in endocrinology. That means that I get referred all of the patients with salt disorders in the hospital, and then that's 50% of my time, and 50% of my time I spend on the medical take, admitting patients and looking after them and discussing with all the GPs, ANPs, and other people out there for patients coming into hospital. So to begin, what we're going to talk about is why it's important. So hyponatremia is important because it's, hypo and hypernatremia are important because it's pretty much the most common electrolyte disturbance you're really ever going to see in primary care and secondary care. On my medical take, it account just hyponatremia, low sodium, counts for about 15 to 30% of admissions. And it's frequently associated with life-threatening pathologies. The last thing is it's really difficult for people to really understand why it happens, and so that's why this talk is really helpful, because hopefully by the end of it you'll have a much better understanding of how to deal with these patients and how to manage them. So what we're going to do is we're going to start with hyponatremia, and that's going to be the bulk of this topic because it really is much more common and there's a lot more to know about it. So we're going to start with a case presentation of Mr. Andrews. So Mr. Andrews is an 86-year-old who presents confused following a fall. His past medical history includes dementia, hypertension, type 2 diabetes. On examination, he's confused. His AMTS, his mental test score, is 3 out of 10, which is very, very low. He is tachycardic. His blood pressure is a little on the low side. He's borderline pyrexial at 37.9. His investigations reveal a hyponatremia, a sodium of 129. He's got raised inflammatory markers, mild AKI, and ECG showing sinus tachycardia. His chest X-ray is normal. So this is the kind of person that I see all of the time coming into hospital. And so what we'll do is we'll use his case to contextualize what we're learning and how we're approaching hyponatremia. So the first thing we need to think about is what's the severity. So mild hyponatremia is about 130 to 135, so that's just below the normal limit. And at this point, it can pretty much be managed in the community in a kind of outpatient, in a primary care basis, because usually these happen transiently and they get better. And it's very much asymptomatic. At moderate hyponatremia, between 120 and 129, again, it tends to be asymptomatic, possible a tiny little bit of confusion, but usually not at all noticeable. Sometimes a little bit of an unstable gait, but again, usually not noticeable. It's only really when you get to severe hyponatremia do you tend to get proper symptoms of being very unwell if it's happened quite acutely. But usually, pretty much all the patients I see, they describe that they're finding it a little bit difficult to walk, a little bit confused, not quite sure what's going on, but not usually as symptomatic as you'd expect them, despite how low sodium they've got. What are the potential causes of hyponatremia? Well, I think this is a pretty helpful way of breaking it down. You've got the very common on one side, so that's your dehydration and your medication. So your dehydrated patients, either because they've had excess fluid losses, they've not been eating or drinking as much, or they've been unwell and therefore, for example, got a fever, therefore they're losing more fluid from sweating. Or medications, common medications being antihypertensives, diuretics, and we'll talk more about that in detail in the next couple of slides. The next most common kind of patient group I'll see are those who are fluid overloaded. So those who've got the failures, and because of that, they've got peripheral edema. Essentially, it's not that their sodium is low, it's that their fluid is high, and that's caused a dilutional effect, which lowers their sodium. And finally, the ones that I get very excited about, but don't happen that commonly, are the endocrine disorders. And so that's just something to bear in mind, because if that's something that you're considering, then it might be helpful to get specialist input more early on. So essentially, for most people, it can be quite easy to work out why they're hyponatremic. Essentially, they're just a bit dehydrated, they're a bit unwell, and it's all the other pathologies that are happening alongside it that's making them very mildly hyponatremic. And as soon as they feel better, then that'll correct. Or they're a little overloaded, and again, as soon as you treat that with some diuretic, with some medications to help with whatever's causing them to be overloaded, at that point they will get better. But what I'm going to go through is how to apply a systematic process such that, whatever the case, you are able to work out what might be the underlying reason. And so a detailed history and exam are very helpful. Specific paying attention to a couple of things. So how much fluid the patient is drinking, their medication history, and any signs of malignancy, and finally their fluid state. And I'll show you what important signs to examine for are. And then investigations, and we'll talk again about what investigations and how we can apply them. So when you're conducting an assessment of fluid balance, so the first thing you want to do is rely on what your history is telling you. Are they having diarrhea, vomiting? What's their intake like? And that's really helpful information. And then in examination, the thing that's often quite obvious are when they've got peripheral edema or sacral edema. And then you can also use a JVP to work out whether the patient has got too much fluid, overloaded. And then working out whether your patient is hypovolemic is far more challenging. So some of perhaps the most sensitive sign is using kind of postural blood pressures. So what happens when you get them to stand, so from lying to standing at 1 minute and 3 minutes, does their heart rate rise? Does their blood pressure drop by 20? So that's suggestive they've got postural drop, and that's perhaps the most sensitive and specific sign for hypovolemia. A lot of people rely on mucous membrane and skin turgor, which is helpful in your younger population, but your elderly population who've lost a lot of the skin elasticity, not so helpful. In terms of the initial set of investigations you're going to do, well, the initial investigations you're going to do are you're going to do some routine bloods to find out any other underlying pathologies that are contributing to this. A urine and serum osmolality, and I'll talk about what that tells you in a second. A urinary sodium as well, and then a basic endocrine screen. Specifically, it's the cortisol. And what I recommend is doing it at 8 a.m. The reason being is if you ask patients to do it at 9 a.m. Particularly if they're in hospital, there's a delay. So this is more helpful in your kind of secondary care setting because essentially all the doctors, all the staff and everyone will start at 9 a.m. Then they will organise the blood test, and by the time the blood test happens, it'll be 10:30, and so it really won't be interpretable. We know that our cortisol tends to fluctuate during the day, and we're expecting it to be the highest in the morning, getting you ready, your stress response, getting you ready, being like, I need to wake up, I need to get ready for work. And so that's why having it tested around waking can give a nice high value, so we know that the patient doesn't have low cortisol or adrenal insufficiency. If the patient's overloaded, then we should do a screen for why they might be overloaded. So the organs that tend to do that are heart failure, so a BNP, liver failure, so hence the liver tests, LFTs and the clotting, and renal failure, hence the urine dip and a urine PCR. And so whilst you're awaiting the results of these investigations, usually we will give some fluids, hold the medications, because essentially until the investigations tell us what the underlying cause is, we'll assume it's dehydration, and because that's the most common. And there's no harm in giving some fluids, a small amount, 1 litre or so, whilst waiting for all of this to come back. What we use nowadays is the guidelines published by the European Society of Endocrinology. So these are far more updated and far more useful and more validated than the previous information people would use. Those familiar with how we would assess hyponatremia in the past, we would look at who are the patients who are hypovolemic, euvolemic, and hypervolemic, and then use that to work it out. But instead, this applies a really nice and neat algorithm that I'll take you through over the next few slides to work out how to interpret what the underlying cause is. So the first thing that we look at is pseudo-hyponatremia, essentially fake hyponatremia. So the important thing to know is that some things might interfere with your blood test. Usually the lab will pick this up. The things that tend to interfere are fats, protein, and glucose. And particularly the labs usually will pick up fat or protein. So essentially, if you've got a lipemic sample, then it can look quite cloudy and it can be quite difficult to interpret. But also what that does is it artificially lowers the sodium. The protein does the same. It artificially lowers the sodium. But actually, that's a lab technical error. The sodium in the serum is the normal value. It's just the way that the test is run in the lab artificially lowers it. Glucose is a little bit different. What glucose does is when you've got a high buildup of glucose in the blood, the sodium will get pushed into cells. So overall, the total body sodium will be the normal value. It's just the movement of solutes to essentially keep that gradient across. And so, two things that I want you to take away from this slide. One, you can use the serum osmolality to assess whether this might be the reason that the patient's got hyponatremia. Essentially, sodium is the main osmol in your blood. It's the main thing that makes your blood concentrated. So, and serum osmolality is an assessment of how concentrated your blood is. And so if your sodium is low, so should your osmolality. They should match because sodium is the main osmol. But the other way that you could check is you could simply do a VBG if you're in a secondary care setting. A venous blood gas, what the value that adds is essentially because you're using another way of analysing these results, it doesn't fall under the same issues that the lab falls under. And so a venous blood gas will show accurate sodium in fats or protein. What it won't do is in glucose, but you'll also get the glucose value in the venous blood gas. And what you can do is you can correct the sodium based on what the glucose is to work out what the actual sodium the patient has is. The most out of all of these, if there's one thing you take away, it's the fact that glucose is the thing that frequently interferes with that. And so you might find your patients are hyponatremic out in the community, but if you just do a finger prick blood sugar, you'll find that their blood sugar is really high, and it's actually not the sodium that's the issue, it's the glucose that's the issue. And that's something just to be aware of with the amount of diabetics there are out there. To work out what their actual sodium is, I tend to use something like MD Calc, or you can look up all the different formulas. You basically just plug in the values. You plug in the sodium, you plug in the glucose, and it tells you what the corrected sodium is. So now I know I don't need to worry about the sodium. Sodium is fine. Actually, what I need to worry about is the glucose. Let me fix that. The converse is true if your sodium is normal and your glucose is very, very high. So, for example, with someone with a hyperglycemic state, hyperosmolar hyperglycemic state, which happens sometimes in our type 2 diabetics. And so their blood sugar might be 35, 40 with a normal sodium, but that sodium is actually not normal. Yeah, when you correct it, you realize that they're actually hyponatremic and they're very depleted in fluids. And that's why we use serum osmolality to diagnose when a patient's got HHS. And that basically tells us the patient is hyperosmolar and hyperglycemic, hence hyperosmolar hyperglycemic state. once we've excluded all your kind of fake hyponatremias, now we want to concentrate on the real stuff. And the first thing that we need to exclude is whether it's severe hyponatremia. So as you probably remember from before, severe hyponatremia is when the sodium is below 120. And what we're looking for are they symptomatic from this? Do they have vomiting, reduced GCS, seizures, or cardiorespiratory distress? Essentially, if you've got hyponatremia, you've got low sodium, then, and that's happened quite acutely, what will happen is you'll get cerebral edema, your brain will swell. And when your brain swells, it's in a confined skull, there's not much space. And so what can happen is you can get raised intracranial pressure. And your worry is that that brain is going to herniate down, and essentially the patient's going to cone. That's rare, very, very rare. But that's why we're looking for these signs of raised intracranial pressure, because that suggests that things have happened acutely. And when I say acutely, I mean it's happened within 48 hours, because the brain adapts very quickly. It adapts within 48 hours. And so your patients who've been hyponatremic for quite some time, they will not really get any of these symptoms. And just to illustrate that, I had a patient only a few months ago who had a sodium of 98. They were fine. Now, I saw that number and I was horrified, I'll be honest, because your sodium really should be in your triple figures. But their sodium was 98 and the patient was sat up talking to me, mildly confused, but having a good conversation. He was like, well, I was feeling a bit unwell, so I thought I'd call the ambulance. The ambulance came, they took me to hospital, they measured my bloods, and then they started panicking. I was like, well, yes, we're all panicking. Your sodium's 98. But that's what I'm trying to do. What I'm trying to illustrate is the fact that these patients can have really profound hyponatremia but be well with it. And so these aren't the patients that you're worried about. The patients you're worried about are the ones that drop very quickly and get these symptoms. And if they do have these symptoms, then you want to consider whether you want to give hypertonic saline. And so that's often 3%, or some people give 2.7%. The idea is you give a small aliquot, maybe 100, 150 ml at the absolute maximum. And what you're aiming to do is just a slight increase to prevent the patient from getting cerebral, well, to basically resolve that cerebral edema, to prevent the brain from herniating down and causing coning, causing brainstem issues because of the cerebral edema. This should only really be done by a senior registrar or a consultant, because overcorrection is dangerous. Essentially, you can cause permanent neurological damage if the brain is adapted to that hyponatremic state, that state of low sodium, and you suddenly push up the sodium because the brain is not yet ready to get back to that normal sodium. And what can happen is you can get permanent neurological injury, something called cerebral pontine myelolysis. But essentially what it is permanent brain injury because it's been raised too quickly. So you really, really need to avoid that. In fact, we say that you should not raise the sodium by more than 8 to 10 millimoles every 24 hours. So that's 8 to 10 millimoles every 24 hours, or half that in 12 hours, because you can really risk this. And I've seen it before. You need to be very careful about that. So you've assessed whether they've got severe hyponatremia, and in almost all cases, you'll say, no, they don't. And it's best to assume that they don't, unless their symptoms like vomiting and other things are caused by other things rather than the severe hyponatremia. And that's at that point you're going to start looking at this urine osmolality and urinary sodium to work out what the underlying cause, etiology of this hyponatremia is. So urine osmolality. So urine osmolality is looking at how dilute the urine is. And so we're measuring that in milliosmoles per litre. What we're looking to see is the urine less than 100 milliosmoles per litre? Because if it is, urine is very dilute, incredibly so. That suggests that the patient has either had so much oral fluids that they are basically just peeing out water, not even urine really, or in a rare case, they basically had such a low amount of salt in their diet. That's rare. I mean, essentially, we all eat excess amounts of salt in our diet. And so it tends to be those people who are basically only chugging beer, because beer has very little salt in it. All those elderly patients who are basically drinking a lot of water. But the far most common cause is psychogenic polydipsia, which is where people get really thirsty, think they're thirsty when they're not, and so drink excess amounts of fluid, 3 litres, 4 litres, 5 litres, 6 litres, way beyond what they need, in addition to all the food and everything else that they're eating and drinking. So what we're trying to do is fluid restrict these patients. We're reducing the amount of fluid to stop that from happening. And essentially then they just need to eat a normal diet because they'll have more than enough salt in it. If not, you can consider some slow sodium tablets, but usually you don't need those. Conversely, you've got the high urine osmolality, and that's the rest of your patients. So this is found in almost all the other causes. And what we'll do is we'll use the urinary sodium to work out which of these causes it is. And so this is when it's 100 or more. Well, sorry, more than 100. So looking more at urinary sodium. So I think to understand how the urinary sodium tells us what's going on, you really need to understand the RAST system, or also known as the renin-angiotensin aldosterone system. This is the system that our body uses to raise our blood pressure. When our body sees that it's in a hypovolemic state, dehydrated state, or it thinks that the circulation is not so great, it pushes up all of these hormones with the idea to squeeze all of our blood vessels and push our blood pressure up. And so what this is doing is this is working in states when you're dehydrated, when you're hypovolemic, when you lose blood. So when you have trauma and you're having major hemorrhage of some sort. But also it will work in times when you have heart failure. So where your body, where the blood around your body is not pumping, you've not got as much blood pumping around. And so what the body senses is a low circulatory volume. And for that reason, it says, no, I need to push everything up. I need to boost the blood pressure, I need to boost the perfusion. And in the same way, liver failure and kidney failure do similar things. So the kidneys will sense that they aren't getting enough blood. But actually, it's not that they're not getting enough blood, it's that the kidneys have failed. And so what it will do is try and push up the blood flow to the kidneys to make them more effective at essentially doing what kidneys do, which is filtering our blood. So if that happens, then what the body will do, and all these hormones go up, then what the body will do is all these hormones will instruct the kidney to retain sodium. By retaining sodium, it will also retain water, boosting our blood pressure up. And so that's an appropriate response to hyponatremia. Essentially, we're conserving sodium. Conversely, if there's some breakdown of this system, the sodium will be high. I mean, that's inappropriate. And so that will be high either because the kidneys aren't working, and so the whole mechanism isn't working, because we've got some medications that are interfering, so ACE inhibitors or diuretics or other things that essentially have an effect on the system and make it stop working, or endocrine disorders, because essentially it's a disorder of hormones. And so again, the hormones aren't working. And so that's what we're trying to identify here. And I'll break this down again because it can be quite a challenging topic to fully comprehend. So talking about a low urinary sodium. So as I said, this is the body trying to conserve sodium because it senses a low circulatory volume. It suggests either dehydration, so diarrhea, vomiting, blood loss or something to that effect. And in that case, the sodium will be low because the body is appropriately trying to conserve as much sodium, thereby as much fluid as it can, because it knows it's in a dehydrated state. Alternatively, it happens in the failures. As I said, heart failure, liver failure, renal failure. It leads to a state where the body thinks the circulating volume is not quite right. These organs aren't getting enough blood, and that's why they're not working. And so the body's trying to push up the blood pressure to try and improve what the blood pressure, because the heart isn't able to pump and keep the blood pressure up. And so what you'll have two groups of patients. One who are obviously dehydrated because of diarrhea, vomiting, because of postural hypotension, all those examination features that we talked about. Alternatively, you'll have those who are hypervolemic or fluid overloaded. So those with peripheral edema, raised JVP, raised BNP, raised liver tests in keeping with the patient having cirrhosis and ascites, or renal failure with proteinuria on their urine dip and on their PCR. And so that will help you differentiate. If you diagnose the patient and you think that it's all related to dehydration, then the treatment is IV fluids and holding any medications that might be contributing to dehydration, such as diuretics or water tablets that are essentially making the patient pass more urine. And so what we'll do is we'll give some slow IV fluids, particularly if the patient's got severe hyponatremia, aiming for that golden target of 8 millimoles, at the absolute maximum 10, but ideally 8, because otherwise we can risk irreversible brain damage. Conversely, in our fluid overloaded patients who have peripheral edema, sacral edema, raised JVP, the treatment is treating the organ failure. And so we fluid restrict these patients because we know they've got too much fluid diluting the sodium, and that's what's causing the hyponatremia. And we give them diuretics usually, and different diuretics depending on the type of failure, but the most common being heart failure, we would tend to give loop diuretics like furosemide or bumetanide to try and offload some of that fluid and improve the sodium. And so in those situations, you shouldn't be worried about giving diuretics thinking, oh no, this is going to cause their sodium to drop further. Actually, no, that's the treatment for them. On the other side of things, you've got patients with a high urinary sodium. Yeah, the body is losing sodium inappropriately. And so that can be either because we're doing it iatrogenically, we're the ones giving them diuretics and pushing that sodium out, and when it really shouldn't be going out. Their kidneys aren't working, and so their kidneys aren't able to conserve the sodium, or they've got some sort of endocrine disorder that's doing all of this. Whatever the case, if you've got a high urinary sodium, that is unusual because the body is clearly not working, because it's clearly losing sodium when it really should be conserving sodium. And so this is when you start to involve someone like an endocrinologist or a nephrologist, depending on whether you think that this is related to kidneys or whether you think this is an endocrine. So the first thing you really want to do is use the medications. Make sure you have a look at what their renal function is like, and if their USNEs are normal and if their creatinine is normal and the diuretics aren't there, then you really need to consider whether this might be an endocrine disorder. Fortunately, you'll have done those initial investigations. And when you did those initial investigations, you will have identified that cortisol. So, as I said, if it's diuretics or kidney disease, we simply just hold the diuretics and treat the kidney disease. And that will be through whatever is causing the AKI. And then on the flip side, you'll hopefully have that cortisol result, and so you'll know if the patient's got adrenal insufficiency. I also mentioned doing TFTs, that you really need to have profound hypothyroidism before you're going to get somebody who's hyponatremic from it. And so it's worth doing, but if your patient isn't looking that sick, it's essentially they're either close to a coma or bradycardic or pretty unwell, then it's not related to the thyroid. But adrenal insufficiency is definitely something that you must exclude before going down the line of SIDH. So you'll have done that 8 AM cortisol, the initial investigation that we talked about. You'll have got the result. Either the result will suggest that they've got adrenal insufficiency, at which point you're going to consider giving them fluids, steroids, and talk to the endocrine team to help support. Or you're going to get a normal cortisol, which is pretty much almost always the case. It's quite, adrenal insufficiency is quite rare. at which point you're going to consider having excluded endocrine disorders, and that's important. You have to exclude endocrine disorders before you can diagnose that SIADH, purely because they will cause an artificial SIADH, and then you'll be trying to give treatment that just won't work. And at that point, you can diagnose SIADH through that urine osmolality being high, to that urinary sodium being high, i.e. going through that diagnostic algorithm that we've just talked about. And at that point, you diagnose SIADH, and then you think about how am I going to manage SIADH. And that's what we're going to talk about next. So what is SIADH? SIADH is the syndrome of inappropriate antidiuretic hormone secretion. So let me break that down. Antidiuretic hormone is the hormone which basically helps us conserve fluid. So it's the syndrome of inappropriate secretion of this hormone. Essentially, instead of the body releasing all the excess fluid it's got, it holds on to it in the circulating volume. What that means is the sodium gets diluted. This is not a hypervolemic state, in that the patient doesn't have peripheral edema because the circulation is fine. There's no organ failure per se. It's just your circulating volume. You've got an inappropriate amount of fluid retained there. And so these patients tend to be euvolemic. But the way in real life we discover this is we see the patient, we think it could be any of these things. What we know, it's not hypervolemic because the patient does not look obviously overloaded. So it's either hypovolemic or euvolemic. We'll get the postural blood pressure, and that doesn't tell us that it is hypovolemic. So what we'll do is we'll give them some fluids whilst waiting the results, and then the results will show us that the patient's probably got SIADH, going through that same algorithm that I've just taken you through. At the same time, there's sodium, because we've given them fluids. So essentially what we've done is given fluids to a condition which is already retaining fluids, i.e. made things worse. The sodium will go up a little bit because of the 0.9% saline that we've got given, which has got lots of sodium in it, but then it will drop. And so the combination of us having excluded a kind of adrenal or endocrine disorder, the fact that the sodium has transiently gone up and then down, but specifically that it's gone down despite fluids, and the fact that we've gone through the algorithm and it's shown us a high urinary sodium. These patients tend to have quite a high urinary sodium, at least above 30, but often 60, 70, 80. All fits together and helps us make that diagnosis of SIADH. And so because this is a disorder where you're inappropriately retaining fluid, the treatment is to essentially fluid restrict. What we need to do, though, is find out the underlying cause, because fluid restriction will only be a temporary holding measure until we find the underlying cause and treat that so that the SIADH goes away. What are the causes? Well, the causes can include medications. I mean, that's the most common that I'll see in practice. So PPIs, proton pump inhibitors, i.e. your lansoprazole or omeprazole, which patients are so commonly on. Your antidepressants, again, very, very commonly on. And then also your anti-epileptics. Those are the three classes that tend to do it the most. There are other drugs that do it, but these are the most common. Malignancy is another thing that you need to consider. And so that might be the first sign that a patient has got a malignancy. And hence, right at the start, when I told you, make sure in the history that you ask, do they have any red flags of malignancy, that weight loss, that night sweats, that losing blood from inappropriate places? That's going to tell you that they've got malignancy, and actually what you need to do is find that malignancy, and because that will be your chance to pick it up and hopefully find something that you can cure and treat. Neurological disorders, so strokes and anything else that's happening in the brain can do it. And finally, respiratory infections. The most common cancer will be lung cancer, so smoking is very important. And that's why it's really important to do chest x-rays in these patients too, to pick up those respiratory infections or lung cancers. And so the treatment is fluid restriction. And so we'll start with a fluid restriction of about 1 litre We may drop it down further to 750 ml. And you really need to appreciate this is really challenging for patients to adhere to. So only a few days ago, I saw a patient who had SIDH, unknown reason. We're investigating whether there might be a malignancy with a CT chest abdo-pelvis. But essentially, when I spoke to the patient, they were like, yeah, I'm on a 1 litre fluid restriction. When I spoke to the nursing team, they were like, yes, this patient's on 1 litre fluid restriction. When I spoke to the medical team, everyone was in agreement this patient was on 1 litre fluid restriction. But when you actually talked to the patient and broke it down what they were taking, they were on several yogurts, milk with their cereal, several teas throughout the day, and then having 1 litre of water, which was their fluid restriction, and then some soups. And by the time and then some orange juice, by the time you totaled it all up, the patient was having excess of 2.5 litres. In fact, they were, if anything, having more fluid than when they'd come in per day. So they totally weren't being fluid restricted, and that's very common because you don't tend to appreciate the fact that everything you have and eat and drink has fluid in it, and all of those things need to be restricted. And so what you have to make sure is if you are fluid restricting to 1 litre, feel free to put that 1 litre jug, but anytime the patient has any milk, any coffee or anything, they need to take that volume out. And whether they're doing that at home, and each time they eat or drink anything, they take that out of the jug, and so they know that they're going down on that 1 litre and how much they've got left. Or whether they do that in hospital, that tends to be something that that really works for the patient. The other strategy that really works is essentially ensuring you go through everything and making sure you tell them, no, this is all you're allowed to drink per day. And so that covers hyponatremia, and that covers the massive bulk of what we're going to talk about. And so just to summarize, the algorithm is available in the European Society Guidelines. Essentially, you start by looking for pseudo-hyponatremia, so venous blood gas, serum osmolality. If the serum osmolality is low, that's in keeping with the patient having true hyponatremia. You then look to see whether it's severe, so whether the sodium is below 120, and whether it's symptomatic with signs of raised intracranial pressure. So you might want to give some hypertonic saline. Almost always that's not the case because the brain adapts within 48 hours. You look for the urine osmolality to see whether it's very low, because if it is, that suggests the patient is drinking too much fluid, and that you just need to restrict. And then finally, you check the urinary sodium. On one hand, either the urine sodium will be low, appropriately so, because the body is thinking, oh no, I'm in a hypovolemic state, so let me conserve the sodium. And so it'll do that in any dehydration disorder, but it'll also do that in any disorder where it thinks the circulating volume is low, like heart failure. Or conversely, the urinary sodium might be high in disorders where there's a problem with the kidneys or diuretics or the endocrine system. Now to talk about hyponatremia, and this is just a couple of slides. So another case to just contextualize what we're talking about. So Mrs. Andrews is an 84-year-old who presents delirious from her nursing home. She's got advanced dementia. And on examination, she's aggressive and combative during the examination, but otherwise unremarkable. And her bloods show that she's got this raised sodium, but the rest of her investigations are normal. So this is probably the most common case that you will see in primary care, when you're going to nursing homes, or when you're going to homes with people with advanced care packages of care, or in hospital. Essentially, the one take-home message is hyponatremia is almost always a water problem. It's not that the sodium is too high, it's the water is too low, and therefore the sodium is high. And that's a real breakdown, because the one thing that we're very, very good at is thirst. So the moment our sodium slightly rises, or our serum osmolality slightly rises, and we become a little bit dry, we will get potent thirst to drink enough water to prevent that from happening. So this only really affects people who cannot access enough water. So it tends to be the elderly patients, or those who've got dementia, so don't have that as much thirst, but also aren't really able to coordinate to be able to get that glass of water, or those with poor mobility. But it might be that you've got people with all of these factors, but also are now losing water. And so whereas they had enough to be able to get up and have one glass of water every few hours, now they're not able to maintain it because they've got increased fluid losses through diarrhea, vomiting, passing too much urine. And so that's what you really need to look out for, doing a proper fluid assessment. Essentially, any patient with hyponatremia needs to come to hospital if they're expected to receive treatment for this, i.e., they're not being actively palliated. But essentially, when we say it's severe, we'll say it's more than 150. But whatever the case, hyponatremia suggests your patient is very unwell. So the causes, as I said, were fluid loss, the diarrhea, the vomiting, sweating, the diuretics, but also an important cause is hypoglycemia. So having excess sugar will cause you to pass more urine. Just like when we diagnose diabetes and we talk to them and say, are you drinking lots of water? Are you passing lots of urine? Similarly, when they're sugary, they pass more urine. And as I said, it's inability to access fluids. Rarely it might be because they've got diabetes insipidus. But again, if they've got that, that's a condition where you essentially aren't just pass water because you aren't producing antidiuretic hormone to conserve it. But even then, the treatment before that, years back, used to be just drink enough water. Or because we've given excess IV fluids. But again, that's very, very, very rare. You've really got to give 3% or hypertonic saline before you get hyponatremic. 0.9% saline is just not expected to do it. And so our assessment is looking for the underlying cause of why they're unwell and unable to access fluids, specifically looking at the glucose and the calcium, because both of those will cause people to pass more urine. And the aim is to treat it with oral fluids, because essentially what you want to do is you don't want to overtreat. You can give IV fluids, and usually we'll give 0.9% saline despite this excess sodium in there. Because that's not that much sodium, and really what they need is fluid. And so the 0.9% saline will cover it. Whereas if we give them 5% dextrose, which just has fluid, we'll drop their sodium too fast, and we won't get that golden number of 8 to 10 millimoles that we talked about before. It's both are applicable in hypo and hyponatremia. And so essentially it's important that we make sure that we give these patients fluid, ideally orally, but IV if unable to do so. And so that basically covers my entire talk. So from now, if you've got any questions, please ask, because I would love to answer some questions. And then the final thing to mention is my website. Sorry, it's a bit of a shameless plug, apologies. But basically I run a website where I support, where I have experts write articles on all of these things, and I've written an article on hyponatremia and hypernatremia. And so if you want a little bit more information, there's some resources there as well.